Friday, everybody. Welcome and thanks for taking the time to join us this afternoon, especially on a Friday before a long weekend. I know that's a tough moment to capture people's attention. I'm looking forward to a really engaging and enriching conversation today with Dr. Hadal El-Hadi in celebration of Black History Month. I'd like to start with a few housekeeping items before offering a land acknowledgement. First, I'm going to request that everyone keep their videos and their microphones turned off during the presentation. That just allows everybody to use the hide non-video participants feature, and that will also help to spotlight the speaker. We'll set aside about 10 minutes at the end of our conversation today for questions, so make sure that you use the chat if you've got any questions for Hadal today. My name is Natalia Mason. I'm the Community Engagement Specialist in the Division of Social Accountability. I'm joining you today from the College of Medicine's main campus in Saskatchewan. As we gather here today, we acknowledge that we are on Treaty 6 territory and the homeland of the Métis Nation. We pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Like most of you, my life has been enriched and sustained by the care and stewardship of these lands by Indigenous people. My father immigrated to Canada from a small Caribbean island called St. Lucia in pursuit of a better future for himself and his descendants. I recognize that many of the opportunities provided to my family in this country have not benefited Indigenous peoples in the same way, and in some instances have contributed to colonial harms. It's in the spirit of reconciliation and a commitment to justice that I pursue decolonization and health equity for all marginalized communities in Canada. For those of you who are unfamiliar, the Division of Social Accountability is a division of the College of Medicine dedicated to health equity, anti-racist education, community-based research, advocacy, authentic partnerships, and the health needs of underserved and marginalized communities. We engage with and learn from our communities to support relevant, meaningful, and impactful health professional education, research, service, and advocacy. This year, it's our intention to focus on different topics each month, each related to a health equity need in our community. This month, we center our conversation around Black health and a little bit more specifically about Black healthcare providers. For our presentation today, we are joined by a compassionate and driven physician, advocate, and scholar. Today's presentation holds extra special meaning for me as I've known Hadal for nearly 20 years. Her work with Black physicians of Canada has been endlessly inspiring to me, and I take such pride in watching her make such immense contributions both to the healthcare system in Canada and to her community. Dr. Hadal El-Hadi is a resident in the University of British Columbia's Public Health and Preventative Medicine residency program. She is a graduate from the College of Medicine, receiving her MD from the University of Saskatchewan in 2015. Hadal strongly believes in the importance of educating and motivating people into taking notice of injustices and working as a team to improve the lives of those around us. One of the biggest reasons that she pursued medicine as a career was because she wanted to be part of a collective that helps children and adults in Canada and globally have a fighting chance to be happy. She recognizes that given the history and nature of anti-Black racism in Canada and around the world, eradication would be very difficult to achieve. Hadal is one of the founders of Black Physicians of Canada. Her hopes for this organization is to have the best interest of Black Canadians at heart, and as a fundamental priority, create changes to the current system where she can, provide safety nets where she can't. And with that, I'll turn it over to you, Hadal, and I will also share your slides for you.
Thank you so much. Thanks for the invitation, and thanks for the very warm introduction, Natalia. I am an alumnus of University of Saskatchewan. I'm very proud of that. I had my undergraduate degree in English literature from the U of S, and then I have my MD from the U of S as well. So this talk holds a lot of meaning for me. And so welcome, happy Black History Month to everyone, even though Black History Month is every day, but specifically February, but we'll just go with that. Thank you for joining me for this talk entitled Cultivating Community for Black Physicians in Canada. And I'd like to begin to acknowledge the historical oppressions of lands, cultures, and the original peoples in what we now know as Canada, and fervently believe in contributing to the healing and decolonizing journey we all share together. I'm also grateful to Indigenous scholars, healthcare providers, and communities for giving voice and meaning to terms like intergenerational trauma, cultural safety, and racism as a social determinant of health. I wish to acknowledge Black ancestry, a deep and profoundly relevant history of Black peoples across the diaspora, a history, lineage, and inheritance that predates this country, chattel slavery, and colonialism that begins with Africa, an ancestry that recognizes the struggle and survival while honoring our narrative of pursuing self-determination. Today, I stand valued, grateful, and proud to be Black. I have no conflicts to disclose. It's important to understand some terminologies pertaining to racism and how its impact can be devastating in medicine. Let's look at the definition of racism. So racism is the belief that a certain race is inherently superior. It's prejudice or discrimination based on race. It's a political or social system founded on racism. Sorry, Natalia, if you just go back, I just want to say some other things about racism. Racism is defined as any prejudice against someone because of their race. But if we leave it there, we only deal with overt racism that most of the world practices. We're only talking about overt racism, but the real issue is systemic racism, and I'll talk a little bit about that most of the world practices every day. So racism should be defined as any prejudice against someone because of their race when those views are reinforced by the systems of power, and specifically for today's talk, the system of the medical professional and healthcare system. Is there systemic racism in Canada? The answer is clearly yes. It's defined as structures or systemic or systems designed to be advantageous to the majority. So in Canada, it's not the non-racialized Canadians. Here's the thing, systemic racism works with or without you. Systemic racism doesn't mean that there's lots of racists in the system. It means that even if there were zero racists present, the system would still disproportionately harm people of certain races. It's a machine that turns whether we pull the levers or not. By just letting it be, we are responsible for what it produces. Acknowledging the pervasive existence of systemic racism and actively confronting and dismantling unequal power dynamics between groups and the structures that sustain them is anti-racism. Being anti-racist isn't about celebrating diversity. It's about acknowledging the pervasive existence of systemic racism. So kindness won't end racism. A lot of people are kind, but anti-racism will end racism. And I think that's a very important distinction to make. Of late, COVID-19 has shown us that there are cracks within our healthcare system. During COVID-19, Black people were 2 times more, or Black Canadians, and so we'll just separate this from the US and global statistics, but in Canada, Black Canadians were 2 times more likely to die from COVID-19 infection. They were 4 times more likely to be hospitalized for COVID-19 infection, and they were 21 times more likely to know someone who had died from a COVID-19 infection. There's many more statistics, and the list goes on, but I'll just stop there for COVID-19. And based on what had happened during COVID-19, the Canadian government could no longer deny the social how COVID-19 impacted Black Canadians was a direct result of systemic racism. These inequities are not just numbers, but they are an unfair system that needs to be corrected by collective actions and change in policies. Anti-Black racism is a system of inequities in power, resources, and opportunities that discriminates against people of African descent. Discrimination against Black people is deeply entrenched and normalized in Canadian institutions, policies, and practices, and is often invisible to those who do not feel its effects. Here are some more statistics. Social determinants and inequities in the healthcare system. Black youth wait 2 times longer for mental health care than white youth. Black women are 4 times more likely to die during pregnancy and after childbirth compared to a white woman. Black patients are 9% less likely to be admitted to a cardiology unit than a white person. Black patients are 3 times more likely than white patients to have kidney failure. For Black and racialized communities, our silence is killing the minority group, and we're not doing much about it. Anecdotally, we sometimes ignore the role of culture as well. The social determinants of health and how identity-based issues like racism takes a huge toll on the mental health and well-being of Canadians. Anti-Black racism and discrimination are important drivers of inequalities in chronic medical outcomes. They're also important drivers in education, in employment, in housing, and other determinants of health for many Black Canadians. Research has shown that there's a disproportionately higher negative outcomes for Black and Indigenous Canadians when it comes to hypertension, diabetes, heart disease, and death, as well as alcoholism, smoking and drug addiction, crime, unemployment, food insecurity, and lack of housing, as well as lack of access to support and treatment. And so I'll just divert this talk a little bit about how Black Physicians of Canada came to be. In 2020, after the murder of George Floyd on May 25th, 2020, I think what happened is, for the first time, at least in my lived experience, people were shocked. I think because it was so traumatic, it was so visual. It's not like we don't know racism exists. It's not like we don't know that Black and Indigenous Canadians are disproportionately affected by the policing system. It's not that we don't know that Black people are dying all over the world in the hands of injustice. I think we all knew that, but I think what that moment triggered for a lot of people, and Black people included, was that this raw injustice, this very visual moment, turned on a switch for a lot of people, including myself, that this can't be tolerated. People are losing their lives, people are losing their dignity, and being silent was no longer an option. And so on May 26th, the next day, I created the Black Physicians of Canada website, more for the way I handle trauma is through knowledge. I was seeking answers, and I was collating a lot of research and papers to kind of understand how a moment like this can happen. Like, what series of events can allow racism to exist so staunchly. And then, luckily, Dr. Ani Norum, who at the time was the president of Black Physicians Associations of Ontario, created safe spaces for Black physicians and residents to debrief, and basically provided an opportunity for us to talk through a lot of the things that we were going through mentally and emotionally. I think the murder of George Floyd triggered a lot of pain in a lot of people, but I think when you see someone who looks like you, who could be your father, who could be your son, who could be your brother, whose life was so callously just destroyed, I think those spaces were very important. Sorry. Because there is a lot of trauma associated with that. I think a lot of there's a lack of humanity when that happens, and when your humanity is attached to someone else that looks like you, and that's how you're treated, it basically it reflects on how you're treated. And it's not to take away from George Floyd. It's not centering yourself in trauma. It's basically seeing you in other humans. And I think having those safe spaces allowed us to debrief and allowed us to go through what we collectively were grieving as a people. And so I told her about the website that I had built. Thanks. And she basically said, and I told her I wish that there was an organization for Black physicians and trainees, but like a platform that we'd be able to advocate and to be able to go to stakeholders and leaders and tell them that you know, we're in such a position of privilege, and we see Black patients every day. We work with a lot of Black allied health professionals, and we have a lot of Black physicians as mentors and colleagues. So if we just had a collective that would be able to um, not speak on behalf, because Black people are not a monolith, but to provide platforms for advocacy and leadership and mentorship. Um, and she very much agreed, and she became a mentor, and she introduced me to my co-founder Teresa Semalulu, who is a rheumatology resident at McMaster University. And basically we just sat down and we talked about what we wanted this organization to be and what we wanted it to look like. Sorry, next slide, Natalia. And next slide, please. And so in July 2020, we became a federally incorporated not-for-profit organization that represents nationally a collective of Black physicians and trainees in Canada. Basically, our mission and vision is to unite, support, and empower Canadian Black physicians and trainees in the Black community while strengthening leadership roles and amplifying Black voices and experiences within the Canadian healthcare system. Our focus, we have 4 pillars. So we wanted community building and wellness. We wanted advocacy as a pillar. We wanted mentorship and leadership as a pillar, and we wanted education as a pillar as well. Community is one of the most protective and preventative way to deal with racism. Being surrounded by people who love, care, and respect you is critical for success, especially as a trainee going through the healthcare system, especially as a physician. And so for that, what we've done is built a database. We currently have over 500 Black physicians and trainees in our database. It's providing networking opportunities. It's providing safe spaces, whether virtually or in person, to collect, to be a collective and rejoice and celebrate being Black in medicine, but also providing skills to deal with some of the barriers we may face being Black in medicine. The advocacy is basically amplifying Black voices, holding institutions accountable for any policies that might be problematic or protocols that might not be equitable, etc. Mentorship and leadership. I'll talk a little bit about this later on, but we wanted to not only to provide opportunities for leadership within our organization, but to sponsor Black physicians into open positions across medical organizations, whether that's the Royal College of Physicians and Surgeons of Canada, whether that's the Canadian Medical Association, whether that's the College of Family Physicians of Canada, basically amplifying and sponsoring Black physicians into these roles. And then mentorship, which is providing mentorship opportunities for Black trainees and early career physicians. And finally, education. We want it to be a credible resource of information, whether that's through social media, whether that's through our websites, whether that's webinars that we host, for people seeking more information, not just about anti-Black racism, but about Black health and how to navigate the healthcare system while being Black. Things that aren't overtly accessible that we found prior to 2020, but now we realize the importance of providing skills, tools and skills and vocabulary and language to perhaps patients trying to navigate the system, to trainees or physicians as well. And so that was our initial focus. But as we grew quite quickly. We created a board of directors. We got governance training. We had a lot of people approach us to do a lot of EDI initiatives. And what we realized for us to be for us to succeed, we also need to be a sustainable organization, and we need to provide we needed outreach as well. So we needed members within our organizations to be available nationally, whether they were officially part of our leadership or not. And then we like our strategy is develop our governance, host a national conference, which I'm very proud to say Natalia is the co-chair of that planning committee, and we're hoping to have it in October 12th to 15th of this year in Toronto, which will be the first conference of its kind ever in Canada. So we're quite excited about that. And basically it'll be a conference celebrating being Black in medicine. The National Mentorship Program is a success as well. It's also one of its first in Canada, basically matching Black residents, fellows, and early career physicians to Black physicians, and providing that race concordant formal mentorship. And then we're collaborating with organizations. So I did mention some of the stakeholders, but we're also working with the Black Medical Students Association of Canada to provide pathways for Black undergraduate students to enter medicine. We're working with the accreditation committee of the 3 colleges that we were addressing how residency programs will be requiring to have anti-Black and anti-Indigenous racism as a core principle of their residency training program. So that's both protective of Black and Indigenous trainees, but it's also wanting to train culturally safe physicians of any race to provide medical care to patients who historically have been ignored, undervalued, and had such negative outcomes traversing the medical system. And then finally, just creating a robust network of Black physicians and physicians in training. So we've had some accomplishments over the last 2.5 years. I've talked a little bit about the database, the mentorship program, the calls to actions for residency accreditation changes, the periodic wellness sessions. Prior to this year, we've had virtual summits every year just to talk about all the progress that's been done, not just with our organizations, but there's been multiple Black organizations, Black medical organizations that have come out in the last few years that have been created because of this movement, and just giving annual progress reports essentially. The national conference, medical leadership, and sponsorship are some of the other accomplishments that we celebrate as well. And then, sorry, next slide, please. The National Mentorship Program is really important. It launched in July 18th, 2021, and it was done after a short survey was sent out to Black residents asking if they wanted mentorship, and 95% of residents did. And what we did a environmental scan, and we realized that Black high school and university undergraduate students, and to a certain extent medical students, there is potential to have mentorship. Mentorship is available to those cohorts, but we found that once you enter residency, mentorship, and especially race concordant mentorship, just disappears, and you're left to navigate a very critical part of your career alone. And that also happens when you're a fellow and an early career physician. And something we've come to understand is that Black residents and Indigenous residents don't have the same, and if they have mentorship, they don't have the same level of sponsorship as other residents. And sponsorship means wanting to, providing opportunities to progress in your career, whether that's leadership roles, research opportunities, job opportunities, vouching for you when you're interviewing, a lot of things that non-racialized residents have access to. We're finding that a lot of racialized and marginalized residents don't have access to, but particularly Black and Indigenous residents. And so I'm excited of what we've done, but I'm even more excited about where we're going. And so I personally believe that Black Physicians of Canada as an organization has so much potential. And these are aspirations. So these are on our wish list, and this is what we're working towards. But through some of the initiatives and hopefully more initiatives in the future, we're insisting on addressing anti-Black racism via policies and protocols in both medical education and practice. Having annual national conferences with renowned speakers globally, funding research that progresses Black Canadians, and not just research that studies how racism works, but implementing findings from the research, and again, not just research, but Black health as well. Providing annual scholarships to increase and support Black Canadians in medicine, supporting ethical race-based data collection initiatives. Hopefully one day we could have a head office, a brick and mortar office somewhere in Canada that people can physically come into. I'd love to be I'd love to spearhead research and maybe have a Black Physicians of Canada journal one day, and then have national consumer education programs on issues that affect the lives of Black Canadians. So these are aspirations. The only thing that is truly coming into fruition is the addressing anti-Black racism in medical education and practice, as well as the annual national conference. But as we grow, as we get more funding, as we have more people, like we're hoping to employ an executive director, but as we grow, it'd be great to see some of these other aspirations come true. And so finally, what we're doing like with Black Physicians of Canada just kind of boils down to that moment, and just seeing the humanity in everyone around us, regardless of race, gender, sexual orientation, gender expression, ability, neurodivergence, whatever it is just how can I be a better physician if I'm giving care, if I'm providing care to a patient. How do I address my own unconscious or my own biases to make sure that the care that they're getting is the most equitable, the best care they can possibly get? And so I just collated a few slides on just basically how can I respond to racism as a healthcare professional. So I think first of all, we need to acknowledge that racism exists in medicine. Our academic and national organizations have all come to consensus, and we all agree that there is a problem, as evidenced by statements made by these organizations denouncing structural racism and pledging to take action to dismantle it. The editor of the Canadian Medical Association Journal, in a response to an article written by Dr. Ani Norum and Amishare Dryden, titled Dismantling Racism in Canadian Healthcare and Medical Academia. What was important was that that paper had said that there were people who denied the existence of racism in medicine, but the editor in CMAJ responded and confirmed that there indeed does exist racism in the healthcare system. So having people in powerful positions acknowledging and vocalizing that this exists, and yes, publishing statements that there's things that we have to do is important, but even acknowledging that exists is step number 0 in combating the racism that does exist. And then the other side of that coin is dispelling the myth that it doesn't exist. And so I just put in an article that the JAMA editor in the States, so not in Canada, was fired for questioning the existence of it. Yeah, so sorry. Maybe next slide. Then there's the act of education and self-reflection. So racism, whether it's anti-Black racism, anti-Indigenous racism, anti-Asian racism, anti-Semitism, Islamophobia, whatever prejudice that exists, we all have to examine the prejudice that it's not sometimes it's uncomfortable. It makes people uncomfortable when they realize that perhaps they do hold prejudice against certain types of people. It's human nature to question people who are different from you. But what's important in the healthcare field is those those prejudice. It's different if, for example, a barista is racist against you versus whether your nurse or doctor is racist against you, because there's all these micro decisions that are being made throughout the day that physicians and healthcare professionals have to make, that when you have unconscious biases, when you have conscious biases, when you have prejudice, can trigger a series of very unfortunate events and problematic actions that do lead to morbidity and mortality. The numbers that I read prior to like at the beginning of this talk, where I had said Black women are 4 times likely to die during or after childbirth than white women, is a finding that is found not just in Canada, but it's the same in the States. It's the same in UK, where the majority of the population isn't Black. And I think we just have to sit down and ask ourselves, why is this the case? And whose lives do we undervalue and whose life do we value more than others? Um, and doing things like having that self-reflection and that education as members in both academia and in medicine is very important. I think people have politicized or weaponized things like critical race theory, but critical race theory is basically examining a philosophy. The way I see racism is that it's an abuse. It's a way to abuse someone. And you can abuse someone through neglect. You can abuse someone through violence. You can abuse someone through torture. You can abuse someone through bullying. There's many ways to abuse someone. And if you begin to see racism as an abuse, as a form of abuse, I think you hold yourself to a different standard. And it's no longer words like prejudice and bias. It's like, no, you're actually abusing someone and you're denying them their humanity, and you're denying them dignity to, to seek help, to seek care. So I think it's important to understand the roots of where that comes from, and whether it's critical race theory, whether it's philosophy, whether it's listening to experts on this topic, whether it's reading books. There is a form of knowledge that needs to both be removed within us, but also a form of knowledge that we have to understand to be able to understand why we do what we do, and then change the actual actions that are a, re- are a result of our way of thinking. Sorry, next slide. And it's really important to increase representation of Black and Indigenous students in medical school admissions and faculty in academia. I think I'm hoping no one is questioning why do we need to do that. But if you are questioning, that's a fair question, in the sense that what we want as a medical profession is to be able to represent the population that we serve. So if 4% of the population is Black, 4% of our physicians should be Black. It should be a mirror, and it's not. It's very, very much not. There are certain races that are overrepresented, and there are certain races that are underrepresented. And Black, Indigenous, and Filipino students are the 3 lowest culturally or racially represented populations in Canada in medicine. So we have to ask ourselves, why is that the case? Because we have to examine what possible barriers exist and then try to remove them. So having a selection committee that's all white or not Indigenous and not Black allows potential for unconscious bias to influence the decisions we make, even though we may think we don't have unconscious bias. Having prioritizing lived experience, prioritizing what benefits a Black physician or an Indigenous physician can provide to a Black patient or an Indigenous patient. Being able to see a number of Black physicians can encourage, Black high school students, Black university students. You can't be what you can't see, and I genuinely believe that if there are people who don't look like you in certain specialties. It might deter you away from those specialties or jobs or careers. And so it's, and finally, there has been a paper published in the States that um, Black physicians can provide a certain quality of care that is unique to Black patients. And when you don't take it, or and that is true for Indigenous as well. But when you see those articles and those publications demonstrating the actual benefit of having higher numbers of certain races in medicine, you're denying what could be beneficial care to patients of those races as well. Um, Next slide, please. And then advocating for ethical race-based data collection. And the key word here is ethical. I think a lot of times race-based data can be weaponized. For example, if you say only 2% of Black medical students are Black, you can weaponize that and say only 2% are worthy of going into medicine, or they're not smart enough to be in medicine. Look at the numbers. Ethical means like you have to examine the core reasons of why that happens. You have to understand the process behind the numbers as well, and not just use numbers to have a selective argument that errs in your favor. But we in Canada are at a disadvantage because we have not collected race-based data. And we're starting to do that now because we've advocated for it. But we don't know how many Black students apply to medical school. We don't know how many people get interviews. We don't know how many people get denied or rejected for medical school based on race. We don't know how many people enter, or how many Black students or Black medical students enter residencies. We don't know how many Black medical students have academic discipline. We don't know how many we don't know the race of people getting removed from residency. We don't know the data behind career acquisition. So people who are applying for jobs, what is the demographic of people who get it and who don't? How many interviews does one person need to get a job, and is that based on race? So there's a lot of questions that we don't have the answers to because we haven't collected the data to prove what we anecdotally believe. And we may be wrong, but those numbers will help put some light into what we think is happening or what we're seeing is happening around us. And that's just the medical education system, and we haven't even started to talk about collecting data based on patients and outcomes and morbidity and mortality. If it wasn't for us, I think Dr. Norum and the Black Physicians Associations of Ontario were critical in demanding that race-based data be collected during COVID-19. And if they hadn't done that on behalf of Black Canadians, those numbers would never exist, and the issues might still be under the radar. But because they insisted on it, we have such a stark example of how inequities and disparities play out. In the healthcare system, Black people experience poorer health outcomes, which is influenced by access to quality healthcare, environmental racism, and implicit racial bias. When race-based data is not collected, it ignores the impacts of racism and social factors on health. So we want the data to be used to measure outcomes and not to blame the biological, cultural, and genetic differences. And then we want to people have put out commitments and statements about anti-Black racism, but there's been no way to hold these commitments to accountability. So medical organizations, faculty, medical journal editors have all published statements. They've all declared their commitments to addressing anti-Black racism. And to be fair, a lot of them have managed to to keep those commitments. CMAJ has done a great job seeking a position for a Black scholar on critical race theory, having a committee on Black health and Black health education. They published 2 journals dedicated specifically to Black health. So those are the things that like the accountability is there. They've actually followed through on their statements. Some universities have not, and we're working towards that as well. And I just want to put a plug in for the Black Medical Student Associations of Canada, who've done such great work holding universities accountable by providing report cards based on certain criteria. And so I think that holds universities accountable as well. And then I just want to remind everyone that there is a fiduciary duty of physicians practicing medicine. We've all said the Hippocratic Oath, and we all need to meet the CanMed's role requirements. And social equity, anti-racism is part of the advocate role. It's part of the core principle of medicine, and that not just for people who are Black, but every person needs to be an ally in the sense that when you entered medicine, you had vowed to do no harm, and racism is an incredible harm. And so addressing racism is not an option. It's actually a requirement to practice good medicine. And so becoming an ally in medicine, it's someone who makes a commitment and effort to recognize their privilege based on gender, class, race, sexual identity, etc., and work in solidarity with oppressed groups in the struggle for justice. And then we don't have to go into details because I think I'm running out of time, but just truly being intolerant to racism in academia and medicine and hold perpetrators accountable, whether that's making a written account, whether that's reporting to higher ups, and then practicing psychological safety. So promoting healthy conflicts, encouraging people to speak up to change oppressive practice, and to use the platinum rule, which is treat others how you'd like to be treated. And then create changes within the medical education system. So we want to educate medical trainees about racial bias and the history of African and Indigenous people. We do want mandatory training in equity, diversity, and inclusion. And when the mandatory training in EDI doesn't mean that it'll convert racists to become anti-racist, but what it does is it provides people who are neutral or who are nervous to talk about race, vocabulary, language, and understanding about how important it is to do that work. Decolonizing the medical curriculum, encouraging medical electives within racialized communities, questioning the issue of the hidden curriculum and banishing trainees during accreditation, and then date and report racist acts to higher ups. And just to close, racism is a public health crisis. It's no longer a problem. And hopefully we're beginning to see the end of it becoming a crisis, but there's a lot of work that still needs to be done. And then, yeah, we called the government to action, but I think that's it. Actually, Natalia, if you want to go to the next slide, it has all of our contact information. So if you have any questions, if you want to look at our website, if you want to email us, or if you want to follow us on social media, those are the links, or that's the information. So thank you for listening and thank you for coming.
Thank you so much, Hadal. That was just absolutely brilliant, as I knew it would be. I'm so appreciative, like someone else mentioned, of your courage and strength in doing this work. I know it's so challenging when it is so directly related to, I think, your own humanity and the humanity of people that you love and their safety and that kind of thing. So really appreciative of that. I'd love to open it up for questions for Hadal. So if you'd like to turn your cameras on and join us, feel free to do that so Hadal can see all your lovely faces. If you've got questions that you'd like to pop in the chat, go ahead and do that. But I actually have a question to start us off, Hadal. So my first question is going to be, marginalized people, including Black physicians, are often expected to carry a heavier burden of work related to issues of equity, diversity, and inclusion. How can allies respond to that and help to alleviate some of that pressure?
Yeah, I think thanks for the question. I think it's interesting that after 2020, a lot of the leadership roles and a lot of the people approach, I think a lot of Black physicians and trainees will find this. We get approached a lot to do EDI work. A lot of it, and we're not experts. EDI is you need a PhD to understand race theory. Critical race theory is it's a discipline, and you need expertise. But in the way we are asking Black and Indigenous people to provide a service, that it'd be like asking someone who's not trained in interventional radiology to do interventional radiology. It's insane. And so I think for one, yes, anecdotal and lived experience is very, narratives are important. Narratives do help support early EDI work. But when you approach Black physicians and trainees, you can do it. You don't have to approach them for EDI stuff. Like I have a lot of like eye care. I would love to do wilderness medicine one day. I'd love to travel. Like I have so much interest and passion outside of EDI work, and I would love for someone to approach me about something other than EDI work. And I think a lot of Black physicians feel the same. Um, and then the other thing I'm finding is that we're getting sponsorship for EDI roles, but the board of the Royal College of Physicians of Canada and the board of the CMA are still, there's no Black people in it, but they have created jobs specifically for Black people. And so it gives the illusion that work is being done, but when you really examine it, it's really not. So I think number one, power dynamics truly have to shift. Some people have to lose, like they're going to have to give up positions that have notoriously and historically been held by a certain type of person. And then secondly, approaching people who are in the margins about things other than being marginalized, because there's more to our lives than just being marginalized.
That's a really fantastic response. I appreciate that so much. Okay, there's a comment from Mateen that says, thank you for your excellent presentation. Do primary and secondary institutions represent a greater opportunity to fight racism than advanced education institutions?
Yeah, so yeah, I think this is that's a great question. I genuinely think it starts in childhood. Basically, everything is the earlier you treat it, the more preventative and proactive you are, the easier it is to deal with. Um, and you're right, and there are studies that show that in elementary school and high school, Black students aren't getting promoted to advanced classes. They're being disciplined and they're being over policed. They're getting removed at a higher rates. And yeah, there is a lot of work to be done in early education. There's a lot of work, having larger numbers when you're younger, and the further up you go, the less Black people you see. So absolutely, there is a role for primary and secondary education institutions to fight racism. And that's just, I'm not in those positions, so I don't know exactly how to do that, but yeah, the numbers don't lie. Like it would be great to start as early as possible.
I think that that's why some of those mentorship programs are so fantastic as well, because they help to introduce more Black young people into like healthcare professions and that sort of thing. But they also provide positive role modeling for the people in the institutions that have exposure to those professionals. And so it's kind of like dually beneficial. Does anyone else have any questions? Go ahead, Anne.
Thank you very much for your presentation. That is eye-opener and excellent. I had a question around, and it really kind of resonated in my head, is in the media and in our institution, we only take bad examples with Black people or Indigenous people, the things that don't go wrong, the things that we kind of villainize kind of those people in the media, in the culture, and so on. And so I think my question to you is, I think that, to just kind of mentor, to give great examples of people who have been successful, people who have done good things, like change the narrative would be helpful. So I would like to have your perspective on it, and how can we help as kind of people, like me, who are Caucasians?
Yeah, it's funny because so the narrative being that there's negative stereotypes around Black people or Indigenous people is kind of crazy to me, because everyone I'm surrounded by who is not Black or Indigenous is brilliant. And I in the sense that I think obviously exposure to different communities. That's why I think it's so important for medical students and like undergrad students to be exposed to different communities, and not just race, but like every form of patient that they can see. It'd be great to spend time, and like that's why we have a mandatory rural rotation. But it'd be important to have, like, it'd be great to have rotations that deal with LGBTQ issues, to deal with immigrants and refugees, to deal with certain pockets of the population that are ignored and maybe villainized or misunderstood. But that just comes from ignorance and not knowing. And I think how do you change the media's perception? I don't know, because I haven't studied media relations, but as a physician, it's so important to be exposed to different populations. When I think about it, like for example, we don't do enough about disabilities in medicine. People who have chronic pain, people who have mobility issues, people who are neurodivergent. We don't actually spend time with those people, and we have our own stereotypes of what they must be going through. And now that I'm in public health, it's kind of insane to me how little we get training about those populations, and how damaging that really is. So for people who are creating policies to not even understand the populations that they treat. So I think exposure would be incredibly important.
Thank you very much.
Go ahead, Manuela.
Good afternoon, Dr. El-Hadi. Such a privilege to hear you speak today. Your presentation was brilliant, and I also appreciate the things that you interweaved about solidarity with other marginalized groups. My question is, how in the work that you're doing, how are you navigating this idea that if we focus on anti-Black racism or Black specific racism, then we're kind of like taken from the pool of another group, and specifically Indigenous marginalized people? This idea that kind of like there's a limited pool of kind of like resources or attention, and that if we divide our attention, then it's less effective, or something along those lines, which is something that I've heard. And the other thing is, I want to ask you, how do you feel about this giant backlash that is happening in the United States? Just in Florida, a bunch of materials have been pretty much banned, including critical race theory, intersectionality, etc., from advanced high school programs. So I wonder, how are you strategizing to deal with those kind of like backlashes or resistances to the work that you're doing nationally? And congratulations, by the way, by the amazing work that you're doing.
Thank you so much. Okay, so two-part question. The first question, I hope I understand this correctly, because I must understand it, but is the anti-Black racism work we're doing taking away from other work that needs to be done, like in anti-Indigenous work? Is that
right? How do you navigate that perception?
Okay, so, well, again, first of all, we work very close. I think we work very closely with Indigenous populations. So our like, I understand what you're saying, the perception that we're like, if medicine is a pie, we're taking a slice of another person's pie, which is a very dangerous rhetoric to, like, I almost don't even want to, if someone believes that, I don't want to address it because I don't want to give it attention, because it's quite, that the stem of that is quite is just as oppressive as any other racist act. Again, just statistically in numbers, is anti-Black racism is such a big problem, and so is anti-Indigenous racism. And we're not saying one is excluded from the other. And don't forget about intersectionality, that there are Black Indigenous students as well. But when you take I guess my argument against that belief is if you're looking at the world and you take the most marginalized, so if here's the center and the most marginalized, and you center those people, so Black and Indigenous statistically are the most marginalized in Canada. If you take that, and any policy and work you do, it benefits everyone who isn't Black and Indigenous. So the work that I do, or the work that you'll find it's mostly Black women, so very, very marginalized people do the work. All the policies that we're working towards, people who aren't Black women benefit from it. So a lot of women benefit from racism work. A lot of non-Black women benefit from racism work. A lot of non-Black racialized people benefit from racism work. So I guess my argument would be that it's just not true. Like, it's not taking away from anything. If anything, people benefit from, like, people who aren't us benefit more than we do from the work that we do. And then the second question is the backlash. To me, I think what's happening is very dangerous, because it's a lot of the beliefs that's happening now in Florida is the exact same beliefs that allowed slavery to happen, and allowed the Holocaust to happen, and allowed apartheid to happen. Normalizing racism, which is what's happening in Florida, and putting it in legal policy is such a dangerous story. We've seen it play out. It doesn't end well. And so I personally, like, it stresses me out, but I don't know what to do about it, because it's so extremist to me, and I just don't have the power to do anything about it. That I'm hoping that there are forces that are just, maybe we're hearing the worst of the worst, but that there are good forces counteracting that we're just not hearing about. And that's my hope.
Thanks so much for those responses. There's one more question in the chat, and I'm going to ask you in a second, but I did just want to put in a plug. The Division of Social Accountability is embarking on a 3-year-long project called ART MedEd, or Anti-Racist Transformation in Medical Education. And so if anyone is interested in making some of these systemic changes, these curricular changes, that sort of thing, at the College of Medicine at the University of Saskatchewan, we would invite you to join us in that process. We're really excited about the potential that has for change. My colleague Carlin has also posted a link for our next webinar, which is coming up in March in celebration of International Women's Day. We are going to be joined by Dr. Mary Kinlock, who is a gynecological pathologist, and also program chair for Women Leading Philanthropy in the Royal University Hospital Foundation. So that'll be fantastic. There will also be a link to follow the DSA and all of our work and sign up for our newsletter. So last question there for you, Hadal. Oh yeah, and I saw that Dr. Shahab left a comment about additional readings. We will send out all of the resources and everything that was mentioned today as well. Okay, last question. I stand corrected, but think that the problem of racism in medicine is really a reflection of a broader societal problem. How does the organization intend to leverage its privileged position in society to address some of those inequities?
Yeah, so I like, you're right. We do have a privileged position. We're trying to solve a problem we didn't create, is essentially what's happening. What we're trying to do is, with our positions, I kind of already touched on a few, but requiring accreditation changes, requiring Black health to be instituted in the medical curriculum. Basically, having these positions makes it so that it's inexcusable not to do those changes. Like, there's no counter response to why these can't be implemented. And we're starting there, and hopefully as we increase and we grow stronger, we'll be able to work with governments, whether federal or provincial. And yeah, we're just starting. We're just quite early, but hopefully that the work we do becomes more impactful the more we do it.
Well, Hadal, again, just thank you so much for joining us today. I'm really appreciative of your time. I know that there are lots of demands on it, but also just thank you so much for the contributions that you are making to our community and improving all of our lives and health and all of that stuff. And thank you everyone for joining us today. We hope to see you next month.